Welcome to the second webinar of our series of presentation aiming to increase awareness and access to thermal ablation technique and thyroid nodules. My name is Jules Al-Jamal. I'm the current president of North American Society of Interventional Endocrinologists, and I will be moderating today's webinar. We have an excellent scientific panel today who will share their expertise in the field of thermal ablation with focus on percutaneous laser ablation. We will be discussing laser ablation mechanics, its long-term outcome, and comparing it with other thermal ablation techniques, and how to perform laser ablation. To allow the panelists to share their expertise and experience and to fully go through their presentation, we'll be addressing questions at the end of the webinar. We ask everyone to submit their question through the Q&A. You will find that either on the bottom or on the top of the screen if you move your cursor in that direction. Without any delay, let us start our first presentation with Dr. Agustin Andrade. He is the Chief of Endocrinology Department at Mount Sinai Medical Center and one of the founding members of our society. Dr. Andrade.
Good morning, everyone. It's a pleasure to have this lecture about laser thermal ablation. This is a continuation of our lectures about thyroid ablation. In the previous webinar, we talked about radiofrequency ablation. Today, we're going to dedicate to talk about the laser thermal ablation. I'm so happy to share this webinar with Dr. Stefano, Dr. Ganassi, our moderator, Dr. Al-Jamal, Jules, and Johnson Thomas, together with Edward Ganassi from France. We're going to start with the discussion, the introduction of why this laser ablation is so important. So we're going to start saying that during the lifetime of the general population, 60% of the people are going to have thyroid nodules. Fortunately, less than 10% of all the nodules are malignant. Therefore, only 10% of the patients are going to require surgery. But the rest of the nodules, they're going to need follow-up. Many of them, 14 to 20%, they're going to need, despite of the benign pathology, they're going to need some sort of surgery or treatment to decrease the size of the nodule because of the symptomatology. So what are the traditional treatment that we have available? We have the radiation treatment with or without a recombinant TSH or surgery. But now we have the thyroid ablation, including the percutaneous ethanol injections that we give to the cyst. We have the radiofrequency ablation, the laser, the high frequency ultrasound treatment, and the microwave that is not approved in the United States. So there's about 150,000 thyroidectomies in the United States. But very interesting, only 63% of all the thyroid surgeries are for benign nodules and 33% are for malignant. Only 3.4% of all the surgeries are for grave disease. So if we put these numbers and we translate this into the cost of the surgeries in the United States, that is about $13,000 to $15,000 per surgery. And 63% of the patients that have benign nodules, they have surgeries. There's 94,500 patients for benign thyroid nodules that they have surgery. That cost to for insurances and for payers in general, $1.3 billion. So we want to stress out the importance of thyroid ablation, meaning radiofrequency ablation and laser surgery, because the thyroid ablation has been done to patients under local anesthesia, doesn't have scarring, it's an outpatient procedure and have minimal pain after the procedure. Also, the thyroid ablation, they have less chances to develop hypothyroidism, almost nothing. Also less chances to develop hypoparathyroidism, recurrent laryngeal nerve damage, and the recurrence is about 5% after the radiofrequency ablation in 3 to 10 years. If we see surgery, it has a 50% chances of hypothyroidism in partial thyroidectomy and 100% if you do total thyroidectomy. And the rate of the hypoparathyroidism is about 1.5 in partial thyroidectomy and 8.3 in total thyroidectomy. The recurrent laryngeal nerve damage is 1.5 in partial and 3.4% in total. In the chances of recurrence in partial thyroidectomy is 23% in 5 years, and of course is almost zero in total thyroidectomy. But the price in the thyroid ablation definitely is smaller than the price of surgery. So percutaneous laser ablation. What is laser? The light amplification of a stimulated emission of radiation. So it's the basis of this is that atoms usually are in the ground state, and when they receive an external energy, it becomes excited just for a short time, and it returns to the ground state. When that happens, there is an emission of light. This is the light. Okay, when that light collides with another atom that is an excited state, it multiplies the light, and that is called a stimulated emission. So this is an example of emitted light that goes with high energy electrons, causing to have the stimulated state and the emission of the light. So what is the light? Light, this is what you see in the light is the wavelength of the light when it's between 400 and 800 is what you can see. The laser is in this range, in the 1064, that is in the range of the infrared. You can see that over here, the 1064. So this is so more or less a summary. So this is a flash lamp that is giving energy to the high energy electrons over here. This is a mirror, and all the light that goes over here is the laser. So in the case of the laser that we're using, you have the energy that goes to the high electron energy, and then the mirrors over here, and all that energy goes through a little hole that goes through the fiber. So what is the difference between the normal light bulb and the laser is that the laser have high monochromacy, high directional, and they're very coherent in relation to the normal light that is completely the opposite. So what we're trying to do is to raise the energy and the temperature to achieve between 60 and 100 cc's, 100 centigrades of temperature. And we don't want to have more than 100 because then you have carbonization. And less than 50, you need to have many minutes to develop damage of the cells. This slide can show that if you use 1200 joules and you change the volts, when you use 1 volt, you see minimal or nothing of damage. But when you increase the volts, you see that there is more and more volume. But look at this green light. This green is the volume. It shows that when you increase the volume, there is doesn't matter at some point when you have more than 8 volts, you don't have more volume of destruction. And you can see that over here, that when you give a high voltage, the length doesn't change too much, and you see that the width of the damage is not longer or larger than when you use the 3 to 5. So the point of this slide is that the best setting of power to use when you use laser is between 3 to 5 volts. So at this point, I will end my presentation so we can continue with the rest of the webinar.
Thank you, Dr. Andrade, for this excellent summary in the physics. I would like to now present our second presenter is Dr. Stefano Spezia. He is a professor of medicine and chief division of endocrine surgeon at Del Mar Hospital, Napoli, Italy. He is well published in the field of thermal ablation since 2003. He will be sharing with us his experience in the long-term outcome of laser ablation and comparing it to radiofrequency ablation. Dr. Spezia.
Thank you all. Good afternoon. Thank you again to Agustin for having been invited to this special event. Now I'll try to share my presentation. So, thank you again to be with you all and for having been invited to participate in this very interesting event that allows us to share our expertise and achieve various objectives, mainly informing colleagues, but above all patients, about the real possibilities that these new procedures have in the treatment of thyroid nodules. The surgical indications, as you know, are often forced, and patients are very frightened and worried about the consequences of surgery under general anesthesia for possible complications, and also for the presence of a scar on the neck. Another goal is to clarify the real indication to the treatment, offering a variety of options that are tailor-made on the patient and on the lump itself. Finally, clarify that even these procedures, if they are not done in expert hands, can create big problems that can be overcome if there is a great experience and an in-depth learning curve behind them. In this presentation, I'll focus on the state of the art of laser thermal ablation in the treatment of thyroid nodules, longer-term studies on PLA in comparison with RFA. Thyroid nodular disease is a frequent problem in endocrine practice, in particular in endemic areas for goiters in our countries. Thyroid nodules with low-risk sonographic stratification and cytological features may be followed up with a simple clinic and ultrasound control, but part of these lesions grows with time and becomes symptomatic. At present, no medical treatment solves these problems, and surgery still represents the standard therapy for the steadily growing nodules that cause local symptoms and patient concern. Regarding thyroid surgery concern, an important underestimated issue is the quality of life of the patients, mostly women. Their QOL and general well-being may be significantly influenced by the lifelong dependence on thyroid hormone substitution therapy, subtle metabolic change, and presence of a scar in the neck. Thus, in agreement with the general trend towards less invasive approaches for the management of chronic clinical conditions, the use of non-surgical image-guided techniques, minimally invasive thyroid treatments, has been proposed during the last decade for the treatment of symptomatic benign thyroid nodules. At the end of the 90s, thanks to the cooperation with the Professor Pacella, that unfortunately has passed last year, we started to treat thyroid nodules by percutaneous laser ablation. Our goal was to reduce the volume of the nodules, improving aesthetic and functional recovery for the patients. Nodules shrink to an asymptomatic size with restoring cosmetics and physiology of the neck that can return to an excellent quality of life, restoring normal physical activity and social relations. Thus, why not minimally invasive thyroid treatments? These are EBM procedures are safe, reproducible, and feasible, producing a quick response without a scar in the neck, and performed on an outpatient basis. ATA guidelines consider for the first time in 2015 thermal ablation, both PLA and RFA, for the treatment of compressive nodules and recurrence of carcinomas. And according to more recent ETA guidelines, PLA is recommended as a first-line treatment alternative to surgery for benign and toxic nodules as well. Not only in Europe, but also in the USA, thermal ablation is a procedure that becomes more and more considered with a lot of published papers, such as white papers, consensus, and reviews, like this that is in press on surgery. As Augustine presented before, laser is a focused beam of light energy, usually generated by a multi-source diode laser with 1064 nanometer wavelength, delivered through an optical fiber into the target tissue. This is the setting in my operative room where, for the US equipment, an inbuilt laser machine is available. The laser operates with an output power that ranges from 3 to 5 watts as a protocol, and the flat-tipped quartz optical fiber with a 0.3 millimeter diameter laser diameter inside. Laser ablation may be performed either under ultrasonographic guidance with a dedicated device or assistance with a freehand technique that is not so easy to perform anyway. The volume of the lesion is predictable on the basis of these considerations, and differently from RFA, the necrosis develops beyond the tip of the fiber and only for a small amount, about 1/3, around the exposed fiber. But if you don't have an inbuilt machine with laser and ultrasound equipment, for your convenience, you could use an interface named ESI to avoid to buy another system. The interface is able to connect to the US equipment you have for the planning of the ModìLite treatment. In this slide, the moving shot technique of RFA is shown. It's less reproducible and more operator dependent. There is need for a more accurate and longer learning curve than for PLA that is easy to learn and easy to perform in a safe way. Nowadays, although the thermal ablation procedures are not yet standard of care in the United States, the current societal guidelines support their use. Availability within the United States of a CPT code opened a new scenario with an increasing total number of treated cases in the United States. Because these techniques are performed safely in our patient setting, are well tolerated, and the risk for needing thyroid hormone supplementation is negligible, becoming quickly the most appreciated alternative treatment to surgical resection. Thus, in terms of results, we have a lot of papers, but I present in particular this one that is the most recent paper from Giovanni Gambelunghe that demonstrates the efficacy of the treatment in 10 years follow-up. This is the first paper to report 10-year follow-up of patients who underwent a single session of image-guided laser ablation for benign solid thyroid nodules. A median volume rate reduction of 68% was observed at 1 year, which was essentially stable over the first 4 years of follow-up and largely retained at the end of the follow-up. As you can see in the diagram, at 10 years, the volume reduction rate was 59% in respect to 68% at 1 year of follow-up. Another fundamental issue is that the nodule regrowth may occur after laser ablation, and regrowth is a key metric used to assess clinical outcome. Using a cutoff of 50% to define regrowth, no cases were observed at 1 year, and while 3 cases and 8 cases were observed at 4 years and 7 years, respectively. There were no further cases seen beyond this time point. The effectiveness and durability of laser depends on the amount of energy that is delivered to the nodule volume, expressed as joule per milliliter of tissue. Previous publications, mainly of Professor Pacella, have concluded that in general, a dose exceeding 500 joule per milliliter is required to produce good results. In the present study, Gambelunghe used a median energy of 510 joule per milliliter of tissue. 5 patients went to surgery due to regrowth at 4 years, and 16 patients went to surgery for regrowth at 7 years. Laser treatment can and should eventually be repeated over time in order to achieve optimal cytoreduction and relief of compressive symptoms, should the first session not suffice to produce expected results. In my opinion, repeatability is indeed one of the key benefits of this microinvasive approach. It is only advisable to pursue other surgical treatment options after at least one renowed procedure. These results are also achievable in autonomous functioning thyroid nodules. Interestingly, the percentage of nodule volume reduction was the best parameter predicting a normalized serum TSH, whether laser ablation or radiofrequency ablation is used. The initial volume of the nodule also predicts a success of the treatment, understood as a possibility of suspending drug therapy. The response is of 100% in nodules with a volume of less than 5 milliliters, but remains very high, over 90%, in nodules with a volume less than 15 milliliters. For larger volumes, the therapeutic response is drastically reduced. Let me now comment on the paper of Bernardi and Alter that compared the two ablation techniques in 406 patients with benign thyroid nodules. 75% of them were solid. The median baseline volume was 14.3 milliliter for RFA and 12.2 milliliter for laser ablation, reporting a 5-year follow-up for this patient. In the overall study population, radiofrequency and laser significantly reduced nodule volume, where VRR at 1 year was 72% for RFA and 55% for LA, with reduction generally maintained over the 5 years follow-up. Technique efficacy at 1 year was achieved in 85% of the RFA group and 63% of the laser group, and regrowth at 4 years occurred in 16.7% versus 33% of patients, respectively. At 4 years, 8 patients had been sent to surgery in the RFA group, compared with 21 patients in the LA group. These data were confirmed by propensity score matching across a range of outcomes. The results of Gambelunga study are markedly better than those reported for laser in this retrospective study of Bernardi. 1 year technique efficacy was 92% versus 63%. VRR at 1 year was 68 versus 55%. The percentage of patients that were sent to surgery at 4 years was about 3% versus 11%, and regrowth at 4 years 1.5, 1.6% versus 33%. Therefore, considering the findings of the multicenter study, several points should be noted. First of all, the data for patients treated with RFA came from 6 centers, whereas only 2 centers provided data on LA patients, meaning that the results for laser were more influenced by data from each of the 2 centers, thus potentially skewing the results. In addition, the retrospective study design means that there was potential for confounding factors to have influenced the results, even though propensity analyses were anyway conducted. Most importantly, despite the propensity score, the median energy delivered per milliliter was significantly higher in the RFA group versus the laser group, 1,400 versus 350 joule per milliliter. The latter value is considerably lower than the energy delivery in our present study and other previous studies. Therefore, considering these differences, it is evident that the different efficacies between the 2 treatment groups in the multicenter study and between the laser group in the multicenter study and the findings of Gambelunga can be attributed to suboptimal energy dosage. So why it doesn't make sense to consider volume or reduction rate alone to compare techniques? First, VRR doesn't provide any information if not joined with the basal volume. cannot be used alone to compare the techniques. It should be always related to basal volume, cannot be used to measure the clinical outcome. It's a doctor's choice to treat more and get more reduction. In this case, VRR doesn't get impacted by the form of energy. VRR doesn't provide any information if not joined with the basal volume. In the laser ablation versus radiofrequency ablation for thyroid nodule, a 12 months results of a randomized trial that was published on Journal of Clinical Endocrinology and Metabolism in 2021, the authors state at 12 months follow-up, RFA was associated with a statistically significant greater nodule VRR compared to laser. But clinically speaking, symptom score was for RFA 1.3 and for laser 1.6. Cosmetic score was 1.3 for RFA and 1.4 for laser, so are almost the same. Actually, according to societal guidelines, we can say that ethanol ablation is the first-line treatment for simple and or recurring thyroid cysts. Consider thermal ablation techniques for primary treatment of benign non-functioning or autonomously functioning nodules in the appropriate patients. Consider these ablative techniques, especially laser and RFA, to address recurrent metastatic disease in patients who are not good surgical candidates. While more data is needed and support ongoing clinical trials for thermal techniques for primary treatment of low-risk papillary thyroid microcarcinomas and indeterminate nodules, also with the molecularly profiled benign. Finally, there is a consensus among the authors that there is no data to support use of these techniques, and they are generally contraindicated in the primary treatment of thyroid cancer. In very rare circumstances, thermal ablative techniques can be considered for debulking of advanced, poorly differentiated or anaplastic cancer for palliative purposes. We are going to the conclusions. Laser is a precise and relatively tissue-insensitive technique. Got FDA approval in 2018 and CPT code as of May 21. Safety, low delivered energy per milliliter, predictable and accurately easy to plan. Less invasive, it uses a 21 gauge needle that is less than 1 millimeter. No need for moving shot, doesn't affect the dangerous triangle. It's easy to use. We can apply the procedure with single needle or double fiber introduction along the longer axis in a longitudinal plane using the applicator to the probe. It's feasible, available for pacemaker, defibrillator holders and pregnant women. Bipolar RFA not approved for this at this moment. The feedback is immediate from the patient. If you need to calm the anxiousness of the patient, you can perform local anesthesia, but you can also, in case of pain, reduce output power or pull back the fiber that is closest to the capsule. The learning curve is short, is less operator dependent. The movie shot implies a lot of improvisation from the operator. With the laser, the procedure is more standardized and programmed and predictable according to the ModìLite procedure. It's a multidisciplinary procedure and can become the technique of choice in patients with small or recurrent lesions of varying size, ranging from 5-6 millimeter to 3-4 centimeter in diameter. Another important issue on what I would focus your attention is that post-ablation, the nodule will have an altered appearance on ultrasound, and it's important that subsequent imaging is done by practitioners knowledgeable in post-ablation ultrasonography of the nodule, so that unnecessary biopsies of the residual tissue are avoided. So we need qualified personnel, and the learning curve must be really accurate before performing this procedure. Thermal ablative technologies are a feasible, safe alternative to surgery. and for symptomatic benign thyroid nodules and for selected thyroid carcinomas. And these techniques are changing the way some patients with thyroid nodules are managed and will continue to do so into the foreseeable future. But even if necrotic effects are predictable and easy to plan, please strictly apply the program model. Damage of the nerves is very rare but possible. The technique will reduce complication and improve results. It's possible to use the freehand technique, but only for very skilled operator. It's possible to reach anatomical structure not easy to treat with the freehand technique using hydrodissection when indicated. Voice change and pain should be evaluated for stopping the procedure, evaluate vocal cord movement and change the position of the needle or reduce power output. If anesthesia is needed, use the pericapsular lidocaine infiltration. Laser is a precise and relatively tissue-insensitive technique. It's less invasive, no need for moving shot, doesn't affect the dangerous triangle and so on. In my personal opinion, it would be stupid to fight a war between laser and RFA. The war should be between surgery and alternatives to surgery altogether. Too many patients are still sent to surgery because the operators are not even aware of non-invasive alternatives. Thank you so much for your attention.
Thank you, Professor Spezia, for this excellent presentation about the long-term outcome. We are gonna move now to our next presenter is Dr. Johnson Thomas. Dr. Thomas is the section chair of Mercy Endocrinology, Springfield, Missouri. He's also an associate faculty at Missouri State University. His practice focuses on thyroid nodule and thyroid cancer, and he has a special interest in artificial intelligence and integrating that into medicine. Dr. Thomas will address how to perform laser ablation in office settings. Dr. Thomas, please.
Hi, all. Can you see my screen well? So today we'll be talking about performing laser ablation. So at present, we'll talk about the current guidelines. As Dr. Spezia mentioned, the ACE guidelines and the ETA guidelines recommend using thermal ablation techniques. The ACE guideline in 2015 documented considering laser or radiofrequency ablation for solid or complex nodules that have symptoms. It could even be cosmetic symptoms. In the 2020 European Thyroid Association clinical practice guideline, they also recommended using minimally invasive procedures for benign thyroid nodules with either pressure symptoms or cosmetic concerns, and who doesn't want to do surgery. They also considered the cost and risk benefits between surgery and thermal ablation options and recommended these for benign nodules. There was also a statement regarding using minimally invasive procedures for young patients with small toxic nodules. So what are the indications? We use it for symptomatic benign nodules. Symptoms meaning difficulty swallowing, change in voice, pain, cosmetic disfigurement, tightness or pressure in the neck, or neck tenderness. Some patients might also experience shortness of breath due to a large thyroid nodule. So what are the possible contraindications? Inability to keep vital structures out of the zone of injury. We'll talk a little bit more about it in another slide. Inability to stop anticoagulation, eggshell or coarse calcification, and inability to get into the thyroid nodule because of calcifications or prior neck scarring due to radiation or other surgeries. Allergy to substances that are used in laser ablation. We'll talk more about it, but mainly to lidocaine, ethyl chloride, etc. Nodule with a large cystic component. It's a relative contraindication. You can actually drain the cystic fluid and then use a laser to ablate the solid area. At present, it's not recommended for treating malignancies, but there are studies going on. Now, how do we screen the patient and prepare the patient for the procedure? We recommend getting TSH-free T4 and thyroid antibodies. We do a thyroid ultrasound for all the patient, obviously, and calculate the volume of the nodule. If the patient hasn't had a biopsy in the past, we do a biopsy, make sure there is no malignancy. We do a neck examination, and we do that 1 meter away from the patient, regular neck posture, then neck extension and swallowing, and document under what circumstance we can actually see the nodule. This will help in the follow-up in the future. We also do a Pemberton sign. Then the patient signs an informed consent. We also perform a laryngoscopy before the procedure. This is done by our ENT colleagues to make sure that in the future, if there is any complications, we have a baseline. And this is the equipment. As you can see on the left-hand side, that's the laser equipment. In the middle, you can see the planning interface, which has a touch screen interface. And then there is the laser fiber and the introducer needle. On the right-hand side, you can see the needle guide. So we use a 21 gauge needle and we put the laser fiber through it. And the fiber projects about 3 millimeters out of the needle. And as Professor Spicia mentioned, the coagulation, most of it happens in front. The 2/3 of the coagulation happens in front of the fiber and 1/3 happens behind it. And it's kind of an ellipsoid area. And this is kind of a schematic representation of how it will look in an actual thyroid nodule. As you can see, there is a zone of injury. So that's the area where the thyroid laser application is happening. And that's where the tissue damage is occurring. So we want to make sure that the major blood vessels, trachea, and all the structures are away from the zone of injury. And this is our laser room. And well, it actually needs an ultrasound to be complete, but this can be a test. And, you know, doing laser treatment is very similar to doing a biopsy. If you can do a thyroid biopsy, you can definitely do laser procedure. Essentially, it's actually putting a needle in with actual better guidance compared to laser. We can see where the needle is going. We have the needle tracking technique and everything available on the software that we're using. We can see where the area of injury will be. So it's essentially much similar to actually doing a biopsy, and you do not have to move around the needle. Once you put the needle in, you press the pedal to give the laser, and that's about it. Now, how do we plan the procedure? Initially, I told you we'll measure the thyroid nodule volume, and based on it, from this table, we can figure out how much energy we need to give, how many needles we have to use, and if we have to do a pullback. Pullback meaning once we put the needle in, we give energy for, let's say, 10 minutes, and then pull it back so that we can ablate more regions. So we don't usually use more than 1 or 2 pullbacks. And this is the planning software. As you can see, the green lights are the planning lines where we intend to put the needles. So there is no actual needle there. We are intending to put these needles in these areas. And the cross marks are where the needle tips will be. And you see the blue circle or the ellipse, that's the area of thyroid that will be treated. So we can very well make sure that the vital structures are out of that ellipsoid region. And using the software, we can find the position of the needle before we even put the needle in. We can choose different angles. We'll talk a little bit more about it later. We can figure out how many needles that we need to use, because if you add more needles, that ellipsoid region will change, the volume will increase. And we can see exactly where we need to put our needle tip. And when we actually do the procedure, we can see the needle tracking through those green lights. So it's a very easy procedure in terms of placing the needle. And we can also figure out how many pullbacks we want to use, and that will also increase the volume treated. Now, these are the different angles available, and this is how we actually connect those to the ultrasound probe. As you can see, depending on whether the nodule is shallow or deep, you can choose different angles. And the actual procedure, it's usually done as an outpatient procedure. You can do with either 1 or 2 medical assistant, depending on your expertise and need at that time. Before we start the procedure, we test the laser fiber, making sure that laser is coming and it's done. Then we sterilize the area where we are going to put the laser in, just like we do in biopsy. You can use chloralprep or betadine. Then this is different. Different people do different techniques, but in our institution, we use lidocaine to just numb the skin, not internally or the needle track. There's an option to just use either chloride spray, but we do not use lidocaine to numb the needle tracks just for the skin. Then we cover the probe with the probe cover. We attach the guide kit, and depending on the angle that figured out initially, we attach the guide kit. Then we put in a 21 gauge needle and put the laser fiber into that needle. Make sure the fiber is in the right position using the ultrasound and the interface that we talked about. You start the laser by pressing the pedal, and after, let's say, 10 minutes, if you want to stop and pull back and do another 10 minutes, you can be done. During this procedure, we'll monitor the vital, especially pulse ox, and we have sterile dressing available if there is any bleeding or if you want to put pressure. And once the procedure is done, you extract the fiber followed by the needle. You do an ultrasound to make sure there is no bleeding or any untoward complications. Then we put a Band-Aid and an ice pack. We observe the patient for 1 hour in the clinic. And this is the whole schematics. Initially, we plan. That's actually seen on the left upper hand side. Then we insert the first needle. If you need, you can put 2 needles in. Then you insert the fibers into those needles, and then you monitor the vitals and do the laser treatment. And this is actually one of the first experiments that we did. We ablated a pig liver. As you can see, a nice area of ablation inside the cut area of the pig liver. And what to do if there is patient concerns. As with the biopsy, patients have different pain tolerance and stuff like that. So you had to be very cognizant about it. If there could be mild pain when we insert the needle. There could be referred pain to the back of the neck or the ears. Many a times the pain is due to the needle that is close to the thyroid capsule. So you can reposition it. If that doesn't help, you can actually stop that fiber only and continue with the second fiber that's inside. But in very rare cases, if there is pain persistence or cough, the procedure should be terminated. Now, how do we follow up? We usually give a patient a call the next day to make sure how they are doing. If there is severe pain, local swelling, or fever, they are asked to contact our office. Then we set up an appointment at 3 months, 6 months, and 1 year follow-up. During these visits, we do a visual inspection, symptom assessment, and ultrasound and thyroid labs. Thank you. That finishes my talk.
Again, thank you, Dr. Thomas, for excellent presentation. I think we're going to move now to our next presentation with Dr. Edouard Inacia. He's assistant professor at University of Montpellier in France, and he will share with us his journey of implementing percutaneous laser ablation in his clinical practice. Dr. Inacia, please.
Okay, you can see the screen. It's okay?
Yes, perfect.
So hello to everybody, and thank you for inviting me to talk about laser thermal ablation, how I did it and how I do it now. I'm very happy to discover the North American Society of Interventional Endocrinologists as the French Association of Thyroidology was born in my little town of Sète 2 months ago. My disclosures. So I started laser ablation in 2014. 7 years after, I think I can share with you what I call a holistic evolution. I will tell you how I started thermal ablation in general, how I did it, what I learned through these 7 years of learning and wisdom curves, and how I do it now, included in my everyday practice of endocrinologist. In my opinion, when I started endocrinology, I discovered thyroidology. Endocrinologists practicing ultrasound at an expert level, FNAB, then CNB. And very naturally, I came to interventional thyroidology about 7 years later. And when you're a Padawan, you're always grateful to your masters. My friend Jean Tramaloni, who wrote the rules of nowadays thyroid ultrasound 40 years ago. And when I was taught ultrasound, he talked about the first publications about laser. And I said to myself, one day, I will be on my own from diagnosis to treatment. Hervé Montpessin, he said, I have a dream. I must travel to Albano to see laser procedures. I will let you know. And 3 years later, he performed the first French procedure. And I said to myself, next year, same day, I will have performed my first. And great thanks to Enrico Papini, because he told me now it's time to do it. So I went to Albano, then at the American hospital I'm now working in, I learned laser, and I started in 2014. I was first scholar and cautious. It means I started with my own patients who trusted me. And then I told them about this procedure. You have to perform surgery, but I just learned this. If you trust me, I think we can do something. I performed the 2014 diagnosis procedure, clinical examination, TSH, calcitonin, scintigraphy, if hot nodule suspected, 2FNAEB, Bethesda 2. And then I used Pachella's and Giancarlo Bizzarri's technique with 300 joules. Thomas just told about it. But most important of all, I did not have access to RFA, but I was referred patients with large nodules. I was forced to optimize laser thermal ablation to get good results. So just think about it. I am scholar and cautious, but sometimes skeptical and rebel. I think that's the way toward optimization. I did not trust the amount of energy. And very, very quickly, I came to almost 800 joule per milliliter for some nodules, but around 500 or 600 joule per milliliter. I thought planification is useful, but too theoretical, and I ended up performing what I called finalizations at the upper pole and lower pole of the nodules. And I had the intuition we would have a problem with margins, and I very often aimed at the margins. These were my first intuition from 2014 to 2016. What did I learn? First, I learned RFA, and I oscillated between RFA and laser intuitively. I could not explain, and I think nowadays, I cannot explain very clearly why I have the feeling for laser and radio frequency for some patients, but indeed, I have it. I learned the moving shock technique. I learned to treat the largest treatable node volume, and sometimes I learned to schedule before the first procedure 2 or 3 procedures. I think at about 30 milliliter, I said, just think about a second procedure. And I learned to deliver the largest possible amount of energy and sometimes to spare danger zones. Of course, with the experience, I learned complications, pain, reassurance. The practitioner's attitude matters. My attitude, what I say, what I write, and I use lidocaine, of course, but of course, hypnosis, music care, local anesthesia, etc. I learned dysphonia, the 3 types of dysphonia, due to the lidocaine sometimes, due to a compression by a nodule. When you treat a nodule with thermal ablation, it becomes very hard, and it can have a compression on the recurrent laryngeal nerve, and of course, heat injury. I learned the preventive hydrodissection, the curative cold glucose injection. I learned nodular rupture with laser and RFA. Man, woman, old or young, it does not seem so influenced by the amount of energy. I think it's still unpredictable. I think in the literature, many teams do not report the nodular rupture. When I see in France, the percent of nodular rupture, it's not possible that there are so few in the literature. I had one Horner syndrome, one carotid injury, and I swear that having a good surgical team at the next door is very important. I had one tracheal injury. One must have chubby adrenals to go on after this, but so I went on. And I learned regrowth. I learned about the initial ablation ratio and residual viable tissue. I only have 10 minutes, so I cannot comment longer, but I learned that what is relevant is the initial volume, is a good pre-procedure microvascular study, and today's ultrasound machines allow this study. I learned about the amount of energy. Pain must be mastered. If the patient has pain, you cannot work peacefully. and I learned to treat the margins. Okay, we saw what Professor Spizza showed us, but I think, in my opinion, it's a matter of mastering the technique. It's not the technique itself, it's the people holding the fiber, holding the probe. Nature said it's safe, rapid, safe, and effective. And of course, look at the first studies. Even here, with my own personal study, 600 joules per milliliter. Okay, we know about quality of life. I learned the meta-analysis consecration in 2017, the efficacy after 3 years, no size effect, operators experience, and correlated to deposited energy. And autonomous nodules, the size matter, the very nice study of Gambelung with the stratification of the initial volume and the success of ablating. And now with such study, I always perform laser ablation for less than 5 milliliter hot functioning nodules. These were my personal data after 3 years working with good results. And we showed with Hervé Montpessin that laser or RFA, you know, with the experience, now you see our curve, this is high few, but laser and radio frequency have the same efficacy at 18 months. And to finish, I learned the learning curve. And for radio frequency, we know that it's at about 50 patients. I think with laser, we're between 30 and 50. But I swear, now I have more than 250 procedures behind me, that you have new curves and what I would call the wisdom curve. But you see, with the learning curve, you deposit more energy and you treat larger volumes. So my conclusion is, beyond the learning curve, you have the wisdom curve. And now, 7 years later, I think we have to perform a wise diagnosis with, of course, the classical, but also the CNB, molecular biology, scintigraphy. A wise pre-procedure ultrasound, of course, diagnosis, thyroid, danger zones, feasibility, but also the microvascular study. A wise, secure, and effective procedure with the new planification tools compared to what I knew in 2014. The good compromise between energy and ablated volume, and add some moving shots to your pullbacks and light and flight techniques. And never forget a wise strategy. Go behind, and you will see that thermal ablation is integrated in a wide therapeutic strategy with combined techniques, combining laser with radioiodine, with percutaneous ethanol injection before the procedure. Never forget, what do I want to treat? Professor Spizza and Thomas reminded that you want to treat symptoms, not an image, and sometimes learn to say no. I think second treatments are not failures. Look for the polyps, look for the stents. I wanted to show you in 30 seconds the new images. Now you can choose between debulking and complete necrosis. I wanted to show you here the sympathetic plexus you can see on 20% ultrasounds, the vagal nerve you all know, but also other nerves. Here, a microvascular study with classic Doppler. Sometimes you have some vessels here, but look here, when you have this after a procedure, it will regrow. I learned about, like this, the lidocaine local anesthesia, and I always perform lidocaine local anesthesia. Now you see progressive injection around the capsule and the perinodular muscles. The more you do it, the better you do it. I learned here hydrodissection. You see this nodule is very close to trachea and it was very vascularized. So now I protect the trachea with glucose. Here is another picture of this. And to finish, of course, laryngoscopy is good, but now I perform laryngeal ultrasound. At the end of a procedure, you see, I can see here the vocal cords moving. I know I didn't touch There is no injury on the recurrent laryngeal nerve. So I would like to thank you all the people who I worked with, and I learned this, and I'm very happy to teach this, to transmit. Thank you for your attention.
Thank you very much, Dr. Ganacia, for this excellent presentation. We're going to move to Dr. Andrade again, who's going to share with us some additional information about the coverage by insurance for laser ablation and barriers related to the laser ablation implementation and practice in the United States.
Hi, everybody. We're going to continue the webinar. It was an excellent presentation from Dr. Ganacia, Dr. Spezia, and Thomas. So what do we need to do to start performing the percutaneous laser ablation in the office? So what are the barriers? Is the price of the equipment, the training skills that we need to achieve, the administration and coordination, reimbursement. Is very safe to be performed in the office. We need 2 persons to do the procedure. So as far as the equipment, we have the EchoLaser system that comes with the ESI, which is the EchoLaser sonography interface using the ModìLite. We have the ultrasound device. Any ultrasound device that have a video output will be necessary. Then the 18 gauge needle, the needle guider, the alcohol lidocaine, that is used for the majority of the physicians, gauze and gloves. This is a tray in my office where you have the lidocaine, the needles for the lidocaine. This is the needle that we need to put the laser. We have sterile gel, the alcohol swab. These are the guiders for the needle. This needle over here, and the fiber. So this fiber goes in this needle once it's inserted. So administration and coordination. We need education materials to the patient, an informed consent that the patient can sign, and we need a licensed person for question and answers when the patient call inquiring about the procedure. What about the reimbursement? So we have CPT code category 3, which is the 60699, which is the same as the unspecific radiofrequency ablation with the newly approved modified 0655T. This is specific for laser and was approved this year, but it was approved by the American College of Physicians, but it's going to be available next year. Currently, all my patients are being self-paid, and that's what we do in our practice. But I'm looking forward next year, we're going to start using this code, and we'll see what happens. What the training options, there are training options available in the United States and Italy. What we recommend is to call the National Ultrasound and inquire about the training, because this can be performed and personalized by whatever your office or your setting needs. Without, I don't want to finish without, this is a real case in our practice that we were training. This is our first patient using the software, and you can see over here the needle using the ultrasound and the laser. So I want to thank Dr. Spezia and Dr. Ganacia. Dr. Thomas Jonas is part of the NASOIE, but I want to thank him also for the wonderful lectures. Also want to thank the National Ultrasound, especially David Cernick and Laura Fitzgerald, for the wonderful support that we have had Over here, you have the web for the national ultrasound in case that somebody's interested to also talk to them for training or any other purpose. Again, I want to thank for everybody to be with us in this wonderful webinar. If you have any question, please, we're open now for any question that you might have.
Okay, thank you, Dr. Andrade, for this excellent presentation again. Let's kind of move to a few questions we have. So the first question, I'm gonna ask the panelists to share with us their experience. It's mainly about choosing the right nodule for the right technique of ablation. How to choose radiofrequency ablation versus laser ablation. Is there any specific a size that you prefer one versus the other? And is there any importance for the type of nodule, solid versus mixed thick solid, in that choice? I would start by asking Professor Spezia to give us his opinion, and then Dr. Gnacia also to share his opinion about that, as he's been doing both techniques.
Okay. As you know, I use both technique, laser and RFA. Usually, I prefer to treat small nodules by laser ablation, while when we have mixed nodules with a large fluid component, I prefer to use RFA. If there is a shape, particular shape of the nodule, and the disposition on the isthmic, on the isthmus of the thyroid gland, I prefer to use radiofrequency ablation. But it doesn't matter that one or the other is best to use, because I think that both techniques are very safe and are very effective if the indications are correct, and if the operator is very skilled in these maneuvers, in this procedure. One difference, the main difference is the use of RFA on patients that are defibrillator or are defibrillator older or pacemaker older. In this case, if you don't have the bipolar possibility to treat the bipolar needles to treat this nodule, it's the best technique to use is laser. Or also in pregnant women where radiofrequency is contraindicated because the flow of energy passes through the uterus. So we prefer not to use this technique. So it's a matter of choice that is operator. In this case, it's operator dependent, the choice you do, because in my opinion you can do almost in all cases both procedures, but it's a preference of a personal preference of the operator, use one or the other technique, in my opinion. So I don't have a specific advice to do for this. I'm curious to learn from the other colleagues and speakers if they have an opinion different from mine.
Thank you, Stefano. So I would say feeling. In cases, hot functioning nodule, as I said, the literature says that you have to choose laser because 100% success beyond 5 milliliter and 90% between 5 and 15. But you have to be very complete around the nodule, just like a malignant tumor. With benign nodule, as you said, with all the contraindications, okay, we do this, and we know that with mixed nodules, laser is very effective because the heat is going in a very homogeneous way in all the nodules. But beyond all this, it's a matter of feeling. I don't know why, but I will choose this is for laser. And I would say it's a personal preference that sometimes after two big radio frequency, it's very relaxing to have laser. And you can choose, like these surgeons, sometimes change the technique regarding to their intuition. So that will be, I admit that under 30 milliliter.
I completely agree with you regarding the autonomous functioning thyroid nodules. Laser is very effective for small nodules, not more than, not greater than 5-7 milliliter. While RFA, in my opinion, is more effective because you can treat the margins of the nodule in order to achieve the complete clinical result. And there is a recent paper that we published on Frontiers of Endocrinology in which we apply the vascular technique that I think is not possible to apply with laser. We perform, before to treat the nodule, we perform the ablation of the main afferent artery to the nodule. In this way, we completely devascularize the nodule and then we treat them. This way, I was able to treat nodule, autonomous functioning thyroid nodules of 70 milliliter in one session. Probably was a matter of fortune. Was a single case I treated of autonomous functioning thyroid nodule with so large volume with one session that was effective, and it was demonstrated by CT scan after 1 year. After 3 months and 1 year after the procedure. So this is a possibility, but for laser, I think that to achieve efficacy, we need to treat smaller nodules. But as you mentioned before, we have not to forget that we have radioiodine that we can apply if we have to treat large nodules, because you shrink the nodule, then you can apply a lower dose of radioiodine to achieve both results, the shrinkage and the functionalization of the nodule.
Another question we have is basically, can we comment on which the ease of use, RFA versus laser? Which one is easier for the practitioner who are able to perform both? Which one they feel like this is easier for me to learn and perform?
So the laser is very easy to be performed because you go through a guider, you put the needle precisely using the software, and really, if you can do the biopsy, you can do this in a very precise way. You don't need the training and the skills to do the technique for the radiofrequency ablation. Another thing that, aside from the size of the module that Dr. Ganassia and Dr. Spiesa were talking, is also that laser probably is going to be a little cheaper to be performed in the United States, and that's another thing that is going to be important. So it's easier and it's cheaper. I just want to share that with you. I don't know if Dr. Ganassia has something to say about that. And probably in France have the same situation, that the laser is cheaper.
Not now. Yes, it's cheaper with one fiber, not with two fibers. But I would like to add something. soon, now ETA is going to publish the guidelines for thermal ablation for malignant lesions. We are going to need to be very precise, sometimes in zones, in danger zones. And I think laser, in this case, will be as effective as RFA, but more precise for these lesions. I think one of the future of laser thyroid thermal ablation is malignant lesions.
I
agree with you.
I would say thank you all for.
I agree with you, and I think
Sorry, Professor Spiza, if you have additional comments, please.
Okay. I think that laser is not only easy to perform, but is also easy to learn and is easy to teach, because as Augustine mentioned before, if the practitioner is an endocrinologist, is a surgeon, and so on, that is skilled with the fine needle aspiration biopsy, it's all. You have nothing else to learn, because the technique is very simple, and also with a guide you can use freehand technique, but usually with the ModìLite treatment you have a plannable program with a mechanical device apply on the probe with a guide to insert the needle. So there is no problem. It's easy to apply.
Another question we got is there any group helping in set up training for laser ablation for physicians in the United States?
So right now we're providing some teaching for doctors that are interested in to develop the laser in the office. But one of the important things also is that they can call the ultrasound national, the national ultrasound, I'm sorry, and also they can inquire about this. They can probably help each physician in a more personal way to see what they need, and even get the equipment. I understand, and I don't want to talk for them, but they're helping the doctors if they want to obtain the training and the device, etc.
I think we reached the end for the time for our webinar. I would like to thank our panelists to share with us their time and experience, and all of you who were able to join us today in this webinar. I would like also to thank National Ultrasound for providing the hosting of the Zoom webinar. Lastly, on our behalf of our society, if you are interested to become a member and to receive our future newsletters and information about our upcoming webinars, and have access to recording of this webinar and previous one, join our society at nasoie.com. Thank you very much for your time, and I would hope to see you all very soon.